Good afternoon, ladies and gentlemen. A very warm welcome to all of the dignitaries and participants to today's CME titled Unravelling the Viral Puzzle Challenges and Strategies in Transplantation, jointly organized by the Center for I3, Manipal Institute of Virology, and the Department of Nephrology, KMC Manipal Mahi. We are honored to host a gathering of experts and learners who share a common passion for advancing our understanding of viral infections in transplantation medicine. Today's session promises to offer rich insights into some of the most pressing virological challenges encountered in transplant recipients. To formally commence the program, I invite Dr. Chiranjay Mukhopadhyay, Director, Manipal Institute of Virology, to deliver the welcome address.
Very good afternoon. I think who are on the online, we are audible.
Yes.
Thank you. So, most welcome, all of you. Very good afternoon for being here. Today we are discussing about a very burning topic. You have all heard of end-stage renal disease, and renal transplantation is a major support to handle end-stage renal disease. But challenge lies many folds while there is renal transplantation. One of them major is viral infections. All over the world, if you see per year, almost 90,000 to 1 lakh renal transplantation. And India, it is over 88,000. But everywhere where there is renal transplantation, the major challenge is the viral infections. And if we talk about viral infections, it is mainly 5: CMV, Epstein-Barr virus, BK virus, hepatitis C, hepatitis B. Today, we are going to talk 3 major of them and definitely some more. About the infections, if you talk about CMV, you will see that in renal transplantation patients under immunosuppression, almost 30 to 50% chances of having cytomegalovirus infections. There is a study 2 years back is done in AIIMS, New Delhi, where they have reported in 400 patients, 38% CMV viral infections. If you see the Epstein-Barr virus, there is post-transplant lymphoproliferative disorders. These can happen. In case of BK virus, there is a study from Chennai where they are saying 7% chance of having the infection in renal transplants. Patients having hepatitis C infections, if they are being treated, their survival rate with transplantation is much more. So there is an integral connection with the viral infections along with transplantation. So what is the way ahead? Few things we know, like all microbiologists who are sitting here, next generation sequencing and quantitative assay, PCR assay, is giving us an idea about the viral load, help us to monitor the patients. Some new antiviral drugs like CMV, DNase terminase inhibitor complex drugs, some drugs which are targeted toward the T cells, especially against the BK viruses, some vaccines against the CMV or Epstein-Barr viruses. These are the upcoming good news, which we hope that it will help us, help the patients to survive better. And if you look for the future, definitely the future, I think it is bright. If we can have targeted, personalized immunosuppressive therapy or prophylaxis protocols, if you have integrated surveillance program, if you have vaccines, if you have drug delivery models, and now in the era of AI and machine learning, we should analyze the data to find the more targeted therapy for the patients. So with this, I would like to welcome the resource persons. Many of them are our own. Dr. Ravindra Prabhu, ex-head and Professor Nephrology, KMC Manipal. Welcome you, sir. Dr. Praveen Kumar Tirlangi, Associate Professor, Infectious Disease, KMC. Praveen, most welcome. Dr. Nitin Gupta, Associate Professor, Infectious Disease, KMC Manipal. Nitin. And Dr. Arvind Ramanathan, most welcome you, sir. He is the founder director, Enable Biolabs India Private Limited. I welcome all the faculty from nephrology for infectious disease from Manipal Institute of Virology and other departments, all the research scholars, PhDs, and the clinical virology students. Let's enjoy the session. Thank you very much.
Thank you, sir, for the warm welcome. We now move into the first session of this program. It's my pleasure to introduce Dr. Ravindra Prabhu A, Professor of Nephrology, KMC Manipal. Dr. Prabhu is a leading expert in clinical nephrology, holding a DM and DNB in nephrology. He'll be talking about BK viral nephropathy, insights into pathogenesis, diagnosis, and management. Please join me in welcoming Dr. Ravindra Prabhu to deliver his talk.
Good afternoon. Like Shubman Gill, I am not very happy to be the opening batsman, but the audience will find solace that the best is yet to come. Okay, so I'm going to be speaking about the BK virus nephropathy. This virus was considered as some kind of a medical oddity. It's found in almost everybody in the adult population and does not do much. It remains latent in most. So it's something like a student who just comes to the class and sleeps. So as long as the teacher does not disturb the student, the things go well. But the moment the teacher wakes, he's going to ask some uncomfortable questions. So the virus is like that. Okay, so so a patient who's a transplant, who receives a kidney transplant, that is the time this virus will wake up. So it's something unique. This virus will never be found in the native kidney. It's not going to be seen in the native kidney. It's very rare to see a kidney biopsy of a native kidney with the BK virus nephropathy. Almost never seen. But in the transplant, yes. And just about 25 years back, it was just seen in few units. People thought that it's not going to be there, but it's something blown now. And there's already some consensus guidelines how to manage it. It affects almost 20 to 30% and can cause graft loss in almost 1 to 2% of patients. That means the virus itself causes the graft loss. And the reason is that, as we all know, or we should be knowing, is the fact that a transplant patient, a kidney transplant patient, is basically walking a kind of a tightrope. He's balancing himself on a tightrope. He needs to be on lifelong immunosuppression so that he does not reject the transplanted organ. And that lifelong immunosuppression is going to make him prone to infections. So if the immunity reduces, he will get infections. If the immunity increases, he can reject. And he simply, if he just walks on, we have to remember he gets only one kidney. We all have two kidneys. He has one kidney. And so that kidney is not going to last the full life. So 3 ways is the problem. So here the body has to tolerate the kidney. It should not reject it. The kidney has to tolerate the patient. And when you introduce a virus like this, we need a 3-way tolerance. The body needs to tolerate kidney also and the virus also. So everybody can live together. So with that background, now this is a situation where we don't have a really good guidance on what is immunity. So everybody says that take immune boosters and such kind of thing, but there's no real good measure of the patient's or the person's immunity. It's not like blood pressure or sugar, which you can measure and modify. But the virus knows that. The virus which is there and latent, it knows when the immunity goes down and it simply gets reactivated. So when we have a strategy where we use the virus level itself to know the patient's immunity and then adjust the immunosuppression. And if you are able to use that strategy, you can protect the kidney. So basically, we have the definition at 3 levels. The gold standard is, of course, the kidney biopsy, where when the virus, which is latent, starts replicating in the kidney, it seems to favor the tubular epithelium, and it has very somewhat characteristic cytopathic changes. So that's the gold standard. But like any other gold standard, we cannot just keep on doing invasive tests like biopsies. So it's not possible to keep doing that. But that forms the standard. There should be a cytopathy. We have to prove it with immunohistochemistry and specific diagnostic tests. The virus should be shown in the blood. So that becomes the gold standard, and that's the way the disease is defined. But apart from that, just presence of the viral DNA in the blood at a particular level seems to indicate the fact that, so this is the level 10,000 copies per ml. If the virus becomes more than that, it indicates that in the next few weeks, the kidney is going to get damaged. So anybody who gets this BK virus DNA EMEA 10,000 would have a presumptive, we have to assume that he's going to get into the nephropathy. Then at a lower level, say at 1,000, again, we need to have a sustained level. So if you test at 1,000 level, again test at 2 weeks, it's still sustained. That means again in the next 6 to 12 weeks, this patient is going to get nephropathy. And then possible. The virus is found in the urine, and it expresses itself in the form of the viral tests or in the form of the shed out tubular cells, that is, which look like carcinoma cells called as decoy cells. There are a number of ways to test, but it's called possible because it is not very much indicative that a person who has the virus in the urine is going to get the nephropathy. He may get or he may not get, but it's not a straightforward answer there. So if he has the virus in the blood, it is definitely chance of nephropathy. If he has it in the urine, we have to wait for it to come in the blood for it to express itself in the form of a cytopathy. So this is basically what I have told is the definition for the BK virus nephropathy or DNA EMEA. Now it's a polyoma virus. I don't want to go into the theory of how the virus looks and all that. And I could not find out what is this meaning of this BK. It's the initials of the patient. 1971, some 29-year-old person, renal transplant recipient, got ureteric stenosis. And at that time itself, somebody was able to find out the virus. But over so many years, there's no real good antivirals to that. And it was the time when social media was not there, so we don't know what's BK. But if it had happened now, probably it would be what we would know what's the full form of BK. So coming to the epidemiology, as I told, almost 90% of the adult population will definitely have evidence of having had having had this virus, and the virus comes in childhood itself, and it is transmitted by the feco-oral or the respiratory route. Something very unique comes through the respiratory or feco-oral, but goes and sits in the renal tubular epithelium. If you take the pre-transplant population, 5% will have some amount of virus in the. As of now, when we do a pre-transplant workup, we don't test for this virus because, again, there's no good guidance to say that this will influence the way you manage the patient. Then post-transplant, over the next 6 months to 1 year, almost 1/3 of these people are going to get the latent virus getting activated, and which starts off in the urine and then goes on into the blood. And out of this, half of them almost will get new onset virus in the blood. This is called as DNA. It's not a wiry makes it, we detect the DNA, so it's DNA anemia it is called. And out of that, maybe about out of the total, maybe about 8 to 12% in the first 12 months are going to, the kidney is going to get affected. And as the kidney goes forward over the next 2 to 3 years, the chance of getting the nephropathy becomes less and less. And by about 3 to 5 years, we may not, if the patient can escape and go forward, maybe we will not be seeing the effect of the virus later on. Okay. So what are the risk factors? Which patients? I told that 20 to 40% get um, the nephropathy. So what's the risk factor? So if the donor, there are donor factors, recipient factors, and transplant factors. In the donor, if he already has viruria, or he demonstrates a kind of high serology for the virus prior to donating, certain serotypes of the BK virus. So there are 4 genotypes and number of subtypes are there. Certain of them seem to be more pathogenic than others. If there's a mismatch, so the donor has one genotype, the patient has another, that mismatch, the patient has not been exposed to this genotype, that itself would favor. If the donor is HCV positive, sir spoke about the HCV positive, if it is HCV positive and if there's a mismatch. So basically, we need a virus which is getting transmitted from the donor to the patient. The recipient does not have good enough cell-mediated immunity to pick up the virus and throw it off, and that is the kind of environment where we would see the virus starting to affect the patient. The ones which are in bold are having a high certainty of evidence. So donor has very high viruria or there's a genotype mismatch, the chance is much higher and there's good evidence for that. Coming to the recipient related factors, an elderly male who is who does not have an immunity against the virus, he's seronegative, or if he is receiving a second transplantation, that is the kind of person who is having a more chance of getting the virus. Why males have more chance than females is not well defined, but it has been proved by the epidemiology here. Certain HLA types seem to be protective, especially this B51, HLA B51, or a combination of these. If you has, then the chance of getting nephropathy or a DNA anemia is less. And in the pediatric age group, the younger the child, the more the chance. And if the native kidney disease is obstructive, there the chance of getting the nephropathy is higher. In the transplant factors which increase the risk of the BK virus, use of tacrolimus as compared to cyclosporin. So tacrolimus seems to activate, cyclosporin seems to suppress. Again, there's no guidance that we should use cyclosporin for all patients. And just to give you a perspective, almost 90% of the patients who receive a kidney transplant will be on tacrolimus. So this is not a factor which will make you to stop giving the tacrolimus. Okay. And basically they'll be on 2 other things, one anti-metabolite and one steroid. So more or less the standard immunosuppression would be tacrolimus, steroid, anti-metabolite. And just before the transplant, or we would also give an induction agent. And so the more number of agents you give, the more chance that this kind of virus will flare up. So I mentioned the induction agent. So this is one of the things, T cell depleting agents. If the transplant does not work immediately, what we call as a delayed graft function. So normally in a live donor transplant scenario, as soon as the transplant kidney is placed in the recipient's abdomen and the anastomosis is done, the artery, vein and the anastomosis is done, immediately on the table you see the urine coming. So that's immediate graft function. So in a few patients, especially if there is, it's a diseased donor, that is a cadaver transplantation, or if the anatomy, the vessel anatomy is difficult, you may face a situation where the kidney does not work immediately, that we call as a delayed graft function, and that's a risk factor. Again, indicating that when the graft function is delayed, the immunosuppression increases. The person is still immune suppressed or naturally immune suppressed, plus immunosuppression, chances of flaring the virus is more. Acute rejection episodes, higher corticosteroid exposure, ABO incompatible. That is, you breach the blood group barrier and do the transplant, the chance is more, and ureteric stents. So normally when we attach the kidney to the recipient's abdomen, the ureter is attached to the bladder, and the stent is placed across the anastomosis till it heals. And the presence of the ureteric stent for more than 3 weeks, and that's the chance that the virus can flare up, the BK virus can flare up. So the high certainty evidence is there for a elderly male donor having the BK virus in the urine prior to donation, a seropositive donor giving to a seronegative recipient, or a genotype mismatch, use of tacrolimus, acute rejection, and higher steroid exposure. So these kind of scenario, but this is a kind of scenario we see in almost all the transplants which we do. But this is supposed to have high certainty evidence um, for the flare up of the. So basically, the pathophysiology, as I have mentioned, would be a donor who has the virus in a good enough load, giving the kidney goes to a person whose cell-mediated immunity is suppressed, either naturally suppressed or suppressed by the drugs, and therefore the immune system is not able to clear off the virus. The latent virus gets activated, and as it gets activated, it uses the host machinery. So there are receptors in the renal tubular cells which will attract the virus and take it in, and the virus uses the host machinery then to replicate itself, and as it replicates more and more, the cell gets shed off, it gets necrose, the tubular necrosis occurs, and it also incites a kind of inflammation, surrounding inflammation, and as you naturally know, inflammation will go into fibrosis. So we start with the virus coming into the urine, goes to the blood, incites an inflammation, and then causes the fibrosis unless we do some kind of intervention before that. So what are the manifestations of this virus? The most common, BK virus associated nephropathy, which I mentioned. Very rarely transplant ureteric stenosis. Even though the first description of in a patient with ureteric stenosis, this is hardly ever seen. Hemorrhagic cystitis in patients with allogenic stem cell transplant. We don't see hemorrhagic cystitis in the kidney transplant scenario. And again, less commonly would be urothelial malignancies. Now, what do we do to prevent all this from happening? So, as I told, the virus is most of the time latent, and only when the cell-mediated immunity comes down, the virus will replicate itself. So we need to know when that is happening. So we use the virus itself to tell us when the immunity is coming. So how do we do it? We need to screen for the virus in the blood monthly. This is the guideline which is given. Very difficult to follow a guideline because the tests are not that cheap. Even though we have a good system where we can do this test, many of the patients may not be able to afford these tests. But if possible, we should screen monthly for 9 months and then 3 monthly for 2 years in children up to 3 years. What we could do in our setting is to look for something less, that is the decoy cells, the expression of the virus in the cell. This is more easily done and cheaper, but again, it's not as good as doing the DNA in the blood itself. And it has been demonstrated that this kind of screening strategy definitely improves the outcomes. The reason is that you are seeing the virus before it really causes a pathology, and then you reduce the immunosuppression, you protect the kidney, and that will increase the life of the kidney. So that's how the cost effectiveness comes in. Now, once you're screening, if it's about 10,000, we need to immediately intervene. But if it's between 10 and 1,000 to 10,000, we rescreen after 2 weeks to see if it is sustained. And anytime we increase the immunosuppression, that is, if a patient has a rejection, you give a pulse steroid, you start the rescreening at that point again because the immunosuppression has increased. In a non-kidney kind of transplant scenario, only if there is renal failure, we do the test, otherwise it's not required. And the standard tests, which of course this audience will already know that we need to use the standardized tests, and there is an effort to standardize organizations like the WHO. Now I mentioned the decoy cell. It's called as a decoy cell because it looks like a carcinoma cell. basically a renal tubular cell to which the virus has entered, and it has changed the nuclear morphology. Looks like a ground glass intranuclear inclusion. And if you stain it with a pap smear um, and detect it, it's an indicator that the virus is there in the urine, and that's the time you could then do the blood test. So as I mentioned, the guideline says you have to do the blood test for the DNA every month. If the patient cannot afford it, one of the ways to go would be to do this test, which is much cheaper. And once the decoy cell is seen, then you could look for the virus in the blood. So the natural course of this virus, again, I'm just repeating this. It starts off with a very low viruria, that's virus in the urine, and then it comes into the blood. And once the level goes high enough, it starts affecting the kidney, and then the kidney goes for end stage renal failure if you don't intervene fast. So this is the period at which the intervention would be most helpful. That is, the viruria is just going into the blood. If you intervene at this level, the kidney function will be preserved. So this is the most effective. At this point, it is obligatory that you have to intervene. If you don't intervene at this point, then the patient gets doomed into end-stage renal disease by a preventable kind of infection. There are a number of diagnostics. Again, I'm not dwelling much on that. I already told about the decoy cell. There is something called as a urinary Hoffen. Hoffen means it's an aggregate of the virus looking like a cast. And it's supposed to have a very high sensitivity and specificity for this virus, and the highest positive predictive and negative predictive value, urinary Hoffen. But like all other good tests, nobody can do it. It requires electron microscopy. So only the person who has described the urinary Hoffen probably does the test. We just see it in pictures. Some of the newer tests which are there is to actually look at the cell-mediated immunity, and there is some move towards using donor-derived cell-free DNA as a pointer towards cell death, number of cytokines and chemokines, and something very new is the torquetinovirus. This virus is something like the BK virus. It is latent. It does not cause pathology. It's a very sensitive indicator of the level of this torquetinovirus is a very sensitive indicator of the immune status. So there are some studies which say that you could monitor the level of this virus to know the immune status. Now, as I told, the gold standard is, of course, the kidney biopsy. We cannot do it in all. What are the indications? So we monitor. What we monitor usually is the creatinine. If the creatinine rises by 15%, it's an indication to do the biopsy. New onset blood or protein in the urine. In children, just the presence of the virus in the blood itself would be an indicator to do the biopsy. And of course, the biopsy should be not just the light microscopy. We need to do the immunohistochemistry. That is for the simian virus 40. Large antigen should be looked for to actually define the presence of the virus. Other indication would be if you are part of a trial with predefined time points, protocol biopsies could be done. But more or less in a clinical scenario, rise in creatinine, hematuria, and proteinuria would be the time we would do a kidney biopsy in this. The virus is more, as I told, in the tubules. And so, unlike other biopsies where we take the cortex more or less, we need to include the medulla. Otherwise, the virus is found in a kind of patchy way, and the biopsy may miss it. So it requires two cores are required. And classical cytopathy is described in the form of intranuclear basophilic inclusions, some changes in the nucleus, and inflammation due to neutrophil infiltrations around the place where the virus is sitting in the tubule, and the tubular cells themselves being dropping out. One thing which we need to note is that the same kind of picture can be seen with the patient who is rejecting. There's an acute rejection. And as we well know, the treatment is diametrically different. So it's sometimes very difficult to differentiate between the rejection and this. And how do we do that? We need to standardize the way the biopsy is reported. And there are two working groups on this. One is the most popular one is the Banff working group, and there's the American Society of Transplantation. The Banff working group basically puts it at two levels, morphological levels. One is the replication of the virus. Second is the fibrosis score. And it detects the replication of the virus by means of the changes in the tubules in form of intranuclear inclusion bodies the positive immunohistochemistry for SV40, and the number of tubules cross sections which are affected. It defines 3 levels: less than 1%, 1 to 10, and more than 10%. And then it combines it with this score to classify into 3 levels. The most mild is where the viral load is less, the fibrosis is less. A mid level where the viral load may be less or fibrosis is just starting, or both are there, and both are at the maximum, that is the class 3. And this kind of classification seems to correlate with kidney function and graft loss. As I mentioned, the differentiation with rejection. So how do we differentiate? Basically, we have to look for the virus in the form of the immunohistochemistry or by other evidence. And if that is not seen, then more or less we would say rejection. Okay. Along with the biopsy, we need to look at the blood levels of the virus. The blood levels of the virus, as I told, should be more than 10,000 to correlate with the biopsy findings. As compared to which, if the person is having a rejection, what you would see is that there will be tubulitis without this IHC positivity, or there is a tubulitis which is remote from the viral cytopathy. So if this thing is there, then we can say that the patient has acute rejection. And sometimes we need to do a therapeutic test. So supposing we are having a confusion whether it's rejection or the virus is there, the therapeutic test would be you reduce the immunosuppression and see. Once you reduce the immunosuppression, if it is rejection, the creatinine will go up. Of course, this is not something many of us would not do that. Somebody very brave who's not very concerned about the kidney may do such things. So you reduce the immunosuppression, creatinine goes up, it means it is rejection. And if you reduce the immunosuppression and the kidney improves, then it is a virus. The consensus guidelines give some recommendations for the histopathology. So when do you do the biopsy? As I told, creatinine increase, hematuria, proteinuria, or the patient is a high immunological risk where you have to decide whether you have to reduce or increase the immunosuppression. It has to be interpreted in totality. You can't just take the biopsy as an island and treat the patient. You need to see the lab and clinical scenario also. The recommendation is to report the score, that's the Banff score or the AST score, American Society of Transplantation score, and the antibody mediated rejection can be reported. The T cell mediated rejection, which looks exactly the same as the polyomavirus nephropathy, should not be reported in the biopsy. And of course, it has to be tagged along with the SV40 large antigen. Some of the differential diagnosis, the main differential diagnosis is for us would be the T cell mediated rejection. Apart from that, viruses, CMV virus is not that common now because of the better screening and the use of the prophylactic valganciclovir. So because of that, CMV is not that much seen. Other viruses like the adenovirus and HSV may give similar pictures, but pathologists would be able to differentiate between them. Now coming to the management, how do we manage? There is no good antivirals which you could use. The virus is fairly a benign virus. So the strategy here would be to screen the patient. So as soon as the transplant is done, monthly screening is done for if possible, for the DNA. And once the virus is present and starts going above 1,000 copies, we need to recheck after 2 weeks to see if it is sustained. If the creatinine increases or there is hematuria or proteinuria, we will do a biopsy. So what is the treatment? Basically, the treatment is some kind of reduction. The virus is there, it means that the immunity is already low. So we need to reduce the immunosuppression. The problem with reduction of immunosuppression is the development of rejection. So it's a balance between avoiding rejection and suppressing the virus. So how do we do this? Basically, I told you that there are 3 types of immunosuppression we use. The calcineurin inhibitors, that is the tacrolimus, the antimetabolites, that is the mycophenolate, and third is the steroid. So the strategy here is most people would first reduce either one of them, and the world is divided into 2. Some people reduce first the antimetabolites, that is the mycophenolate, reduce it by 50%, and after 2 weeks reduce it further and see what happens. If the kidney still has the problem, then you start reducing the CNI. The other way to do it is to reduce the CNI, that is the calcineurin inhibitor, by 25 to 50%, and then after 2 to 4 weeks, then reduce the antimetabolic. Some people would reduce both at the same time, which may not be a very good strategy to go forward. Then what happens if the kidney, after all this, goes in for end stage? Can we do a second transplant? The indication is that if the patient's viral load is negative, retransplantation is feasible. There is some indicator that whether we should remove the kidney. The kidney is having the virus, and supposing the kidney goes for end stage, whether it needs to be removed before the second transplantation. Again, that is not the recommendation. We could do a second transplantation without a graft nephrectomy. A number of other agents have been tried. There's no good evidence that they work. So the leflunomide seems to have some antiviral activity. Leflunomide is an immunosuppressive. It seems to have antiviral activity in vitro, but no good evidence to say that it works in a particular patient. Then quinolones, levofloxacin has been used, ciprofloxacin has been used. Again, no good evidence. IVIG and the actual antiviral cidofovir, which itself is nephrotoxic, so many would not use that. Now, to detail about the immunosuppression reduction, basically we target for CNI, we check the drug levels and we target 3 to 5 or lesser. Okay, and then monitor the viremia. Told the two. And what we are looking for is a 10-fold fall in the viremia over the next 2 to 4 weeks. The other treatments, out of all the treatments like leflunomide, that quinolones and IVIG, the one which has got a kind of guideline recommendation would be IVIG. So if we reduce the immunosuppression and still the viremia persists, we could try the IVIG, or if the combined rejection and the virus is replicating, this is a drug which is fairly safe, even though it's very costly, it's fairly safe, and it works against both the virus and rejection. So what we do is give 300 milligram per kg with hydration 3 weekly for 3 months. Again, the evidence does not favor that it really works. But since it is safe, the guidelines say that you could try it. The other drugs I have already mentioned, that is the leflunomide, quinolones, and low dose cidofovir. What are the experimental therapies? No antivirals as such, but probably somebody will come up with that. Vaccines, specific vaccines, neutralizing antibodies. There are trials with neutralizing antibodies. The out and specific adoptive T cells called posoleucel, which can be used for this. Then, what are the causes of graft loss? You have tried immunosuppressive reduction, you have tried the IVIG. Still, some people, a small group of people, less than 5%, would go for a graft loss. And the reason for that is either the nephropathy itself due to the virus, or because of reduction of immunosuppression, the patient goes for rejection, either acute or chronic rejection. So once the patient goes for end stage, in spite of all the treatment given, is retransplantation feasible? And large large data says that the graft survival is acceptable. You can do a retransplantation provided the viral load is near negative at the time of transplantation, and almost equal graft survival is there for the second transplantation. Graft nephrectomy is very difficult to do, and most of the people would not do it, and it is not recommended, even though logically, if you remove the graft, the virus is going to become zero. But we know that the virus comes with the donor, and so that may not be useful. Whether to change the immunosuppression for the next transplant, there is no good recommendation. So with this, I will come to the conclusion. Basically, this virus, the nephropathy results from high level of virus replication. It has the potential to cause graft failure. The gold standard is the biopsy and the histopathology. The only strategy which works, and it works in almost 95% of patients, is to screen, monitor, and reduce the immunosuppression when required, when this virus flares up. So that is the what is going to protect the kidney transplant, and that has to be done in a stepwise manner. So first reduce one, then the other, so that you don't get into rejection. The main danger is getting into rejection, and that is avoided by slowly reducing the in a stepwise way. And the recommendation is to have a protocol for each unit. No other therapy is conclusively useful. So we have all of us try leflunomide and ciprofloxacin or levofloxacin, but and sometimes we give IVIG also. But in a trials, it is not conclusively useful. And in the future, we may get adoptive T cells, neutralizing antibodies, and even vaccines. Thank you very much for patient listening. Question.
Thank you, sir, for that comprehensive and enlightening session. I request the audience to note down their questions, which can be discussed later in the QA session. Now, I would like to welcome our next distinguished speaker, Dr. Praveen Kumar Tirlangi, Associate Professor, Department of Infectious Diseases, KMC Manipal, to deliver his talk on updates in the diagnosis and management of cytomegalovirus.
Very good afternoon. Can someone confirm that I'm audible online? Yeah, this is offline. Yeah. Yeah. Thank you. So we have discussed about Zika virus. That was a very interesting session. Zika virus is a polyomavirus which is extremely host dependent. So it is very difficult to actually give an antiviral because most of the Zika virus replication is based on the host machinery. So we cannot really have antiviral to treat BK. But whereas in cytomegalovirus, it is a luxury to have. We are going to discuss about which antiviral is better. So it is a little bit different. We are a little bit more comfortable treating cytomegalovirus compared to BK virus. But again, cytomegalovirus is called as transplant troll. So till the time the cytomegalovirus is reactivated, you are all very happy. Everything is going well. Once you see a cytomegalovirus in the blood, then it is a little bit irritating. Most of the time, sometimes we really don't know what exactly to do. We do some things based on whatever evidence which is there, whatever guidelines are suggesting. But we all know that sometimes the questions are a little uncomfortable. So we will try to kind of address those questions as well in this next 30-40 minutes. But I want to tell you that don't take any take-home messages from here and don't quote me bedside saying that Dr. Praveen has told me to stop immunosuppression or increase immunosuppression, right? So cytomegalovirus is a DNA virus with a big genome. So it has a lot of immune evasive strategies. If you compare RNA virus with a DNA virus, RNA virus has a small genome, cannot evade immunity, and basically the pathogenesis of RNA virus will depend upon the mutagenicity of RNA virus. So it tends to mutate because it cannot evade immunity. At the same time, the RNA coding is not even if there is an error in RNA coding, it will not get corrected like DNA virus. So the mutations tend to accumulate. But then when you have a good neutralizing antibody, it can be neutralized. So neutralizing antibodies are very effective in RNA viruses, whereas DNA viruses like cytomegalovirus or EBV, for that matter, hepatitis B, they can stay inside the cell for a long time. They can make a latent infection, evading all the intracellular, intranuclear immune strategies and stay there for life. So once you have a cytomegalovirus in the virus in your body, it is there. So in India, the advantage or disadvantage, I don't know, but more than 95% of the people carry CMV virus. So when you are transplanting a patient with a ESRD, end-stage renal disease, most of the times the pattern we see is donor will be CMV serology positive as well as recipient will be CMV serology positive. But where in Western countries you see the CMV prevalence is less, somewhere around 50%. So 25% of the people can be donor positive and recipient negative, which is kind of a very high risk of CMV reactivation. So our discussion is more in positive recipients, because we'll very rarely see a donor positive recipient negative state in India. So before really going into the topic proper, I would like to quiz our ID residents here, Dr. Anjali, Swati Kiran, and nephrology residents as well. So which of the following immunosuppressant is associated with the least risk of CMV infection? Quickly. Sirolimus, okay. Easy. High risk of CMV is associated with serological status. D plus R minus. Identify the false statements. Preemptive treatment is associated with high CMV disease. CMV viremia is associated with high mortality. A negative CMV will blood or plasma CMV will rule out CMV disease, or CMV is associated with increased risk of PCP and aspergillus infection. More than one answer can be right. A negative CMV blood or plasma CMV will not rule out CMV disease. Okay, we'll come back to these questions at the end again. Identify the false statement. Little bit you have to know about this mutation. So can you just take a guess? Okay, which one? Sorry. Anyway, so we'll go ahead with our session at this point of time. So I will be discussing this with a brief introduction, diagnosis of CMV. We'll discuss about this debate of preventive with prophylactic treatment. We'll also discuss about the measuring cell-mediated immunity to guide the CMV prophylaxis. We'll also discuss briefly about antivirals and what is refractory resistant disease. And we'll discuss about mini dose prophylaxis, which most of the centers in India do, but there is a lot of discussion on it as well. The guidelines do not endorse mini dose prophylaxis, but we will really look into the literature. What does it say? And we'll also discuss about a little bit about the duration, right? So as we already discussed, the D plus R minus serological status is associated with higher risk, but most of the times we see intermediate risk with D plus and R plus status. Among the solid organ transplantation, if you are doing a transplants like kidney or intestine, which are immunologically very active, and you have to really give a very high dose of immunosuppression to prevent rejection, the risk of CMV is quite high when compared to heart, kidney, or liver, which are a little bit lower risk compared to lung. So in lung transplantation, the duration of CMV prophylaxis is quite long. Usually in kidney kidney transplant, we decide on 3 to 6 months based on the recipient status. But in lung transplant, we usually give for 1 year of immunosuppression. Then again, we will also discuss about how to assess the net state of immunosuppression. The answer is we don't know how to assess. Probably at the last lecture of this session, we will have some idea about it. And interestingly, mTOR inhibitors, which are like sirolimus, there are more than 10 meta-analyses now that mTOR inhibitors are relatively associated with less risk of CMV disease. Are we using it in the bedside? Are we switching the antimetabolite to mTOR inhibitor because someone is having CMV disease? No. So the literature is still gray, but what I want to tell you is any immunosuppression is immunosuppression. So even mTOR inhibitors will increase the risk of CMV, but when you compare it with an antimetabolites, probably the risk of CMV is less, right? So this is one of the very interesting things. If you go through all the guidelines, it will be very black and white. Do you have rejection or do you have CMV? So if you have CMV, treat CMV, and if you have rejection, treat rejection. Because of the immunosuppression you give for rejection, there could be CMV reactivation. This is how the discussion is. But more interesting discussions are done outside MM7, the coffee shop with Shankar Prasad sir. So you have a patient with CMV reactivation, and also this patient is having rejection. You don't know what has come first, whether it is CMV, because CMV itself can stimulate NF-kappa beta pathways, which will cause inflammation. And CMV will cause steroid resistance. So if someone is on steroid, if there is a CMV reactivation, steroids will act through glucocorticoid receptors, alpha and beta. Alpha is most important. CMV inhibits that translocation of glucocorticoid receptor alpha to the nucleus. So if you are giving 40 mg steroid, patient is doing okay. Now there is CMV, there will be resistance to steroids. So once the CMV is reactivated, it can actually push the patient to rejection. And vice versa is also true. And this data is more clear in something like inflammatory bowel disease or steroid refractory GVHD in oncology. So if CMV basically stays in macrophages, endothelial cells, and epithelial cells, the moment there is some inflammation, there will be reactivation of CMV. That is the reason why you see critically ill patients, you do a CMV viral load in the blood, there will be some blip of CMV virus. That is because the macrophages are proliferating. So if you look into the literature of inflammatory bowel disease, many of these patients who have CMV along with IBD, the people still give infliximab. Infliximab is something which will inhibit the proliferation of macrophages, and they saw that the people have done better. Even active CMV, they have given doses of infliximab, and they have done better. So it is also possible that the patient had rejection now. Because of the rejection, you are seeing a blip of CMV. So the approach to your patient will be very different. So as an ID physician, whenever we get concerned, we say that it is CMV reactivation, so immunity must be very low. You decrease the immunosuppression. Then nephrologist will be like, okay, so patient had basically recently kidney transplant because he's going to die. Now you're telling to stop immunosuppression. ID physicians will be very aggressive, stop everything. So nephrologists are like, okay, but there is rejection. So they will be on the other side because we have to protect the kidney. So probably we cannot decrease the immunosuppression that much, and let us just give antivirals and see. But the reality is something in between, and we have to navigate through it, right? So you have to, first important question to answer is whether the rejection has started first or whether you are seeing CMV reactivation first. If you are seeing CMV reactivation first, probably patient is in a net state of immunosuppression. So your approach will depend upon that. But if you are seeing rejection, then there is a CMV reactivation, the approach will be a little bit different. At this point of time, can I say that probably we can stop anti-metabolite and switch it to sirolimus or mTOR inhibitor? For example, there is a patient with rejection with CMV reactivation. You are treating CMV. We all agree in treating CMV. We are also agreeing on stopping anti-metabolites because those are the things which are associated very high risk of CMV viremia, whereas tacrolimus has little bit of intrinsic activity against viruses and steroids are little bit neutral. That's the reason why you give 1 mg per kg steroids for so many rheumatological patients, and you don't really worry about whether the CMV is going to get reactivated in those patients or not, right? So we'll stop MMF. We will increase the steroids a little bit if there is a rejection because there is CMV is causing steroid tolerance. We will maintain the tacrolimus. But if you really don't want to stop MMF, can we switch that to sirolimus is another question, which is not answered, but is an interesting strategy. The problem with mTOR inhibitors is they will delay the healing. And most of the times when we are seeing CMV, we are seeing CMV colitis or CMV pneumonitis. So it is possible that there is a CMV ulcer in the gut and you started an mTOR inhibitor that led to a perforation of bowel because it will prevent the healing. So the ulcers might not heal. But these are all theoretical concerns. We really don't know what we have to do in this. Second important thing about CMV is most of the trials you see, initial trials when we are comparing one antiviral with another antiviral, the outcome was like what is the percentage of CMV disease, and we are saying that newer antivirals are as good, for example, in prophylactic versus preventive strategy, whether there is a difference in CMV disease. But then people have also seen whether there is difference in CMV viremia. Obviously, in prophylactic strategy, it will be less compared to preventive strategy because in preventive strategy, only after viremia you are irrespective of whether they have developed CMV disease or not, had a poor outcomes in the terms of overall mortality or in the terms of overall graft function. Even in HSCT patients, the overall mortality was high if there is once there is a CMV reactivation because CMV is not immunologically naive. It will actually change everything. It might cause steroid resistance. Now you have a CMV, you have decreased the immunosuppression that can. So you have increased the steroids and there is a CMV infection, ultimately increasing the risk of subsequent fungal infections. And the treatment for CMV is something like valganciclovir, which will cause cytopenias. And there is cytopenias, you are stopping MMF anyway. Then you are discussing about whether to continue the co-trimoxyl prophylaxis or not. The moment you stop co-trimoxyl prophylaxis, there are n number of infections that can come now, like nocardia, toxoplasmosis, or PCP, and many other. Right? So this is the complex situation. These are the indirect effects of CMV. So once you have CMV viremia, overall, if you look at this patient, the outcomes are going to be a little bit poorer than if the patient had no CMV viremia. So let us jump into the diagnosis of CMV. We all know that CMV viremia or DNemia is when you detect a CMV DNA in the blood. But what if the patient is having diarrhea? So diarrhea in a transplant patient could be because of n number of reasons. There are many parasitic infections, strongyloidosis, cryptosporidium, mysospora, cystoisospora, giardia, norovirus, and could be because of CMV, could be because of drugs like celiceptin, tacrolimus. So patient had a diarrhea. You are getting some blood CMV which is positive. So is it CMV colitis or patient is having diarrhea and CMV is negative in the blood, does it rule out CMV colitis? Similarly, in CMV pneumonia, there is a lung patch, patient is having cough, blood is showing some CMV, but is it CMV pneumonitis or is it some other pneumonitis? Or if the blood is negative, can you rule out a possibility of CMV pneumonitis? These are the very difficult questions to answer. So let us look into the gastrointestinal aspect. So if someone is having, you are suspecting CMV colitis, you can do a blood PCR, you can do an endoscopy, upper GI and lower GI endoscopy to look for any ulcers, and you can biopsy from there. You can run a PCR, you can do a IHC, or you can look for intranuclear inclusions in the biopsy sample, and you can also send it for viral cultures. Viral cultures are not practical, but most sensitive are viral cultures. So you have done a biopsy in a case of CMV colitis, and you are not able to find intranuclear inclusions. That doesn't rule out CMV colitis, because as you can see in this study, approximately 25% patients are viral culture positive but not showing intranuclear inclusion. So that means that just because the biopsy is negative, you cannot rule out CMV colitis as well. So how do we approach? Probably if we have any obviously we are going to assess the patient clinically to know whether this patient is actually at risk of CMV or not. But at the same time, if you have something like blood viral load, this more than this is little bit more towards a possibility of end organ disease. So I'll be more careful in this patient. There are some studies where they have shown that if your blood viral load is more than 10 power 4, little bit be worried about a possibility of CMV colitis. So what I'm trying to tell you is, so you have a patient with suspected CMV colitis. A negative blood PCR is not going to rule out CMV colitis. You have to go and do a biopsy. But if your patient's blood PCR is positive, but you have done a biopsy and it is not suggestive of CMV, that will not rule out CMV colitis as well. Especially if you have a viral load of more than 10,000, be very careful. Think probably it could be CMV colitis which you have missed. Probably want to do a rebiopsy, or probably want to treat that patient as CMV colitis. Similarly, in CMV pneumonitis, the challenges are very, very similar. And the extra challenges, most of the times, it's very difficult to do a lung biopsy compared to gut biopsy, especially in the setting of CMV, where you'll have cytopenias, thrombocytopenia. Many of the centers do bronchoscopy, even in the presence of thrombocytopenia, but again, there is some hesitance to do even bronchoscopy, leave the biopsy part apart. So when you're looking at lung, again, if you do a bronchoscopy and BAL, the presence of CMV viral load in BAL will not confirm anything. And absence of PCR, CMV PCR in blood, negative CMV PCR in blood also will not rule in or rule out anything. Here, probably if you are seeing a BAL CMV viral load of more than 10,000, and if you don't have any other explanation for pneumonitis, patient is symptomatic, probably that is the time when you should probably consider CMV pneumonitis. Obviously, doing a biopsy and doing looking for intranuclear inclusions is gold standard, but that is most of the times more common than not. It is not possible in the clinical setting, right? So we'll move to the prophylactics versus preemptive strategy. What is this whole thing about prophylaxis and preemptive? We call it as PET strategy for the preemptive strategy. So in preventive strategy, what you do CMV viral load every week, monitor for any CMV reactivation. If there is CMV reactivation, you treat the patient till the CMV is negative, and then you follow up. In prophylactic strategy, we give CMV prophylaxis for all the patients. Now, the problem with the preemptive strategies, you have to make sure that the patient is coming every week, and you have to make sure that the sample is sent to the same lab, because if there is a variation between different labs, even though there is a standardization, you have to make sure that it is done in either blood or plasma, not once in blood, not once in plasma, and once weekly you have to do. And then the moment there is some blip, there is different thresholds to actually start preemptive treatment. So that threshold is not very well defined. But if you are thinking the patient is at very high risk of CMV, usually we take it as around 200. If a little bit low risk of CMV, probably 500 is a good threshold. But these are all very institutional based. And that is how you do preemptive. What is the advantage? Probably you are looking at 20% of people who never required CMV prophylaxis, and you can avoid Valga and cyclovir in these patients. Very good, but 80% of the times you have to start antiviral. That is the problem. Second issue is, once you are giving preemptive treatment, you are kind of allowing little bit of CMV replication. The idea is if you allow that, probably there will be a immunity which will develop to the CMV. So you can kind of avoid a late CMV reactivation. That is, once you stop prophylaxis, then in next 6 months, there is some risk of CMV, but probably that won't happen with the preemptive strategy. Are there any good studies in liver, in Kidney transplant patients, no. There is one good RCT in liver transplant patient, but that also comes with some limitations. What is the problem with prophylactic strategy? Prophylactic strategy will prevent CMV reactivation, okay, most of the times. So if you are preventing CMV reactivation, you are actually avoiding all the indirect effects which are attributing to CMV reactivation. But at the same time, because you are giving prophylaxis continuously, there could be late reactivation of CMV. Once you stop the prophylaxis, in next 6 months, there could be a CMV viremia or CMV disease. So you cannot prevent a late CMV disease. The another very interesting, very common problem is the side effects of the drugs. So we do have a lot of antiviral options right now. We have newer antivirals like letermovir for the prophylaxis. But the thing is, if someone buys other kidney, you can donate that to buy letermovir. It is that costly. So we are left with valganciclovir. We are most of the centers in India are following the valganciclovir prophylactic strategy. The cost is an issue. The side effects of valganciclovir are an issue. So once you have a valgan causing cytopenias, eventually you have to drop on the doses of Celiceb, like MMF, and which can lead to rejection again. So the if you are having a valganciclovir induced cytopenias, then there is a problem. So people have come with any interesting strategy. Let us decrease the side effects of valganciclovir. How are you going to do that? Decreasing the dose. Okay. So decrease the side effects. Let us probably, if you are giving lower dose of valganciclovir, there will be subclinical reactivation of CMV that might provide a immunity, which will prevent a delayed activation of CMV. Very good. And it is actually cheap if you are giving 450 OD, half the dose of what is it. This is called mini dose prophylaxis. And this is very controversial, but personally, I feel it is very good. So I will tell you what are the reasons for that. So, so I have mentioned about one study in the liver transplant patients where they have found that the CMV disease at the end of 1 year is lower in PREM2 strategy. But if you look at this Kaplan-Meier analysis, you can see that the mortality is higher in PREM2 strategy. So obviously, PREM2 strategy people will have a higher CMV viremia that can lead to mortality. This was not mentioned anywhere in the manuscript. It is there in the supplementary file. And this is one of the secondary outcome, but somehow in the main manuscript, you will not look at this results of the secondary outcome. So I understand that preemptive strategy is interesting. One K-pop is a trial which is going on in kidney transplant patients. We have to see the results of that. But in our setting, probably prophylactic strategy and probably a mini dose prophylaxis. So one of the criticism for mini dose prophylaxis, if you are giving a valganciclovir at lower dose, eventually you might have a CMV which is resistant to valganciclovir. And when there is a resistant valganciclovir CMV reactivation, it is associated with higher mortality, right? So, but why not say same thing with the letermovir? Letermovir is a newer antiviral with a very low threshold to develop resistance. So does it going to, like if you are giving letermovir, probably it will also lead to resistance to letermovir and subsequently higher risk of CMV disease. But however, the study which has been done with the letermovir in transplant patients has not shown significant resistance to letermovir. But interesting thing is they have compared letermovir with the 900 mg of valganciclovir, that is the routine dose. And in the 900 mg of valganciclovir, approximately 10 to 15% actually developed resistance to valganciclovir. So despite giving 900 mg dose, there is a resistance to valganciclovir. So this is one of the argument which can be against mini dose prophylaxis. So why not just look at the literature of mini dose prophylaxis? And but before that, one of the most important or difficult issue is immediate transplant time. So if you have transplanted the kidneys, and some of the patients will have delayed graft function. Now the urine output day one, day two is 3-4 liters, and creatinine is not settled down yet. So how are you going to dose the valganciclovir? It's very difficult. Just because urine output is good, you cannot say that GFR is good. Urine output could be good because of the bad tubular reabsorption, which can happen after the recovery of ATN or ATA. So dosing in this peri-transplant period is very tricky, but usually the approach is keep it at lower doses because there are at least few studies, even if you delay the CMV prophylaxis by a week or 10, it is not associated with higher CMV reactivation or CMV viremia or CMV disease. So you kind of can actually wait till the day 7 till the things settle. But if you want to give upfront prophylaxis, it is okay to keep the valganciclovir at lower set rather than to the other side where you might have developed cytopenias, then you have to deal with reducing antimetabolites, which will definitely increase the risk of rejection, right? So there is a systematic review of this mini dose prophylaxis at least 4 studies, and it is shown that it is associated with decreased CMV disease. Again, all these studies are not big RCTs. The evidence, quality of evidence is not great, but this is interesting that this effect is consistent. So when you're using mini dose prophylaxis with versus routine dose prophylaxis, you are seeing less CMV disease. This is unexpected. Let's see disease. One of the reason could be is that you are not probably stopping antivirals because you have to stop antivirals because of side effects. So it's a good strategy. What about leukopenia risk? It is significantly low, more than less than 7, like it is 70% decrease in leukopenia, decrease in overall rejection because you don't have to stop antimetabolites because that is cytopenias associated with valganciclovir. So I think low dose valganciclovir, which should be compared head to head with letermovir, and that will actually help in countries like us where the cost of antivirals is very high. So low dose prophylaxis can be effective option, something in between prophylaxis and preventive, and something which we can give as a prophylaxis with low side effects and subsequently improving the outcomes, especially when you have a newer antivirals using which we can even treat resistant or refractory CMV infections if patient is affordable. Yeah. So this is one of the study, and in this study you can see that despite of 900 mg of valganciclovir, there are 12% who develop resistance. Now the question is, in kidney transplant patients, you usually have a single function kidney. The other kidney is already gone. So I kept a new kidney. You are expecting an estimated GFR of 60, probably 120 by 260 or 70. For that, actually, if you look at the valganciclovir dose, it is half the normal. So so-called mini dose prophylaxis could be actually the right dose for patients with kidney disease. We follow Cockcroft-Goat formula. That is not for AK, that is not for a post-transplant setting. So there is a basic controversy in how we are measuring eGFR when we are dosing the valganciclovir. The other important thing is the decrease in valganciclovir blood levels and subsequent resistance might not be just related to the dose you are giving. There could be multiple genetic polymorphisms. For example, someone is having polymorphism P glycoproteins in the gut, where the drug is getting excreted in the gut. Whatever dose you are giving might get excreted. And there are many other ways, many other genetic polymorphisms which can actually reduce the valganciclovir. So how about giving mini dose valganciclovir, but monitoring drug levels? And if you are achieving good, worry about it, right? So that is one of the most interesting strategies. The common mistake which we do in our clinical practice is not advising how to take valganciclovir. So ID residents or nephro residents, how to take valganciclovir with food, without food, empty stomach. So it has to be given after a fatty meal. So the area under AUC of valganciclovir will increase by 1/3. So actually 900 mg valganciclovir without food is equal to 450 mg valganciclovir after a fatty meal. So that is the most common thing which we do wrong, and that should be taken care of, right? So what about the duration of prophylaxis? Shall we give it for 200 days or 100 days? In a high risk patients, we do advise for a 200 days, but most of the times we have a R plus recipient where 300 days is enough. That could be followed by probably monitoring of CMV viremia, especially in patients who are at a higher immunosuppressed state, or probably you can just stop it and follow up the patient. Yeah. So now the problem is with the delayed CMV reactivation. So when you're stopping the prophylaxis, obviously there is a risk of CMV reactivation in the next couple of months. How are we going to know who is this patient who is going to get reactivated? Can we measure the immunity to CMV to know whether this patient is going to get reactivated or not is an important question. And this question is, we are trying to answer this question for a long time, not we, the people are trying to answer this question. There are a variety of strategies. One of the strategies is getting the CMV quantiferon because it is an easier thing to do. And it has a binary outcomes like quantiferon of more than 0.2 is protective, less than 0.2 is not protective. So if you have a protective cell-mediated immunity against CMV, probably are more comfortable stopping prophylaxis at that point of time. So you have given 3 months of prophylaxis, you got a CMV quantiferon, it is negative. Probably you don't want to stop CMV prophylaxis now and you want to reassess after some time. So this is one strategy. In R plus recipients, there are a lot of studies and it is showing to be promising. Not in a R negative patient. So if the patient is D plus R minus, the negative CMV quantiferon might not help you. One more Patient is, if patient is having severe lymphopenia, this test will come as indeterminate. So before sending quantiferon, look at the lymphocytes. So what we can do in our setting is at least look at absolute lymphocyte count before stopping CME prophylaxis. So patient has completed 3 months of CME prophylaxis, no complications. Now we are looking at the patient whom you want to kind of stop CME prophylaxis, but the absolute lymphocyte count is less than 600. There is a higher risk of getting reactivation. So if it is more than 600, probably you are more comfortable in stopping CME prophylaxis. This is something which we can easily do. And if the lymphocyte count is less than 600, that lymphopenia, probably the CMB quantiferon might not help also. So at least this is very interesting that we can look at absolute lymphocyte count before stopping the CMB prophylaxis. Let's move on to CMB treatment of CMB disease. We have a lot of antiviral. We will not really go into the details of all these antivirals. Valganciclovir, ganciclovir we use routinely. Effective. They eventually inhibit the DNA polymerase, so it is very effective in killing the virus. Whereas cidofovir also acts to the same mechanism, very effective, just like valganciclovir. The problem is cidofovir is associated with a lot of side effects, especially in kidney transplant patients. You don't want to have a drug which will really affect the kidney. It also affects the eye. It can lead to iridocyclitis. It can decrease the intraocular pressure and blindness. So you really want to monitor proteinuria and vision in the patients who are receiving cidofovir. Foscarnet, again, very effective drug, but very toxic as well. Approximately 30% of patients who are receiving Foscarnet will develop AKA, a lot of electrolyte imbalances, so much that people can develop arrhythmias and neurotoxicity as well. Very costly. I think rarely we have, I think we haven't used Foscarnet for a long time now because most of the times affordability is issue. Now there are two other antivirals which acts by a little bit different mechanism. Letermovir is a ternase complex inhibitor. So once the DNA is formed, the chopping of DNA and egress of the CMV is prevented by letermovir and maribavir respectively. So the problem is, these antivirals are not acting at the level of DNA polymerase, so not very cidal. So when you are looking at a patient with letermovir prophylaxis, if you see here, because you are measuring DNA and letermovir is not inhibiting the formation of DNA. So if you are looking at the peripheral blood for CMV, there could be some viremia, for example, of 500 international units. In letermovir, maybe okay. That's because the DNA formation you have not inhibited. That is one of the reasons why if you are using something like maribavir for the treatment of refractory CMV, because it is not inhibiting actually the DNA virus replication, the risk of secondary reactivation once you stop maribavir will be theoretically high, which we'll show in the subsequent slides. Yeah. So how will you define a refractory CMV? You have a patient with CMV colitis, for example. You have started on ganciclovir, and patient did had some CMV viremia which you can monitor. So after 2 weeks, you had a repeat blood CMV, and if there is no increase in CMV viremia or at least 1 log reduction is what you expect. If it is not there, probably you are looking at something like refractory or resistant disease. Resistant disease is resistance to antivirals. Refractory disease could be because of the immune status of the patient. So patient's immunity is unable to control the CMV replication. So it keeps on replicating, right? So that is the reason why you have to say it as refractory and resistance disease. Because you cannot always say it is the failure of antivirals which is causing the persistent CMV. This is how we define. But again, if you look at this trial, it's Victor trial, which has compared oral valganciclovir with IV ganciclovir. In that, you can actually see the patients who had actually viral load above 50,000. It is taking long time for the viral load to come down. So it is at the 2 weeks, if you are not seeing 1 log reduction, but if the patient is improving, wait for some more time, especially if they have viral load of more than 10,000. You can wait for a week or two and again repeat and see. No low dose treatment for CMV disease. It's only for prophylaxis, which we have discussed. So just because we are saying 450 OD for prophylaxis, don't make 900 OD for treatment. That will definitely lead to CMV resistance. So there are a lot of mutations which will cause antiviral resistance. For ganciclovir, you need a 3 kinase step. One of the kinases from viral kinase, UL97, is required for the activation of ganciclovir to the active form of ganciclovir, which is effective against CMV. So UL97 mutations will cause ganciclovir resistance, but not cidofovir and foscarnet. And UL54 mutations can cause resistance to everything, Most of the times, the ganciclovir and cidofovir mutations area is in the same region, which we call as exonuclease and region 5. So if you're having ganciclovir resistance, because of UL54 mutations, there will be usually a associated cidofovir resistance. Whereas you can have ganciclovir and cidofovir resistance without foscarnet resistance and vice versa. So there will be a complicated situation where you have a UL97 mutation causing ganciclovir resistance, and then a mutation is UL54 which is causing foscarnet resistance. So in this situation, it is possible that patient is having resistance to ganciclovir and foscarnet, but is still susceptible to cidofovir. So any combination is possible. Basically, what I'm trying to tell is you cannot say that because ganciclovir resistance, it is cidofovir resistance or anything like that. Okay. What about newer antivirals? So maribavir inhibits UL97. So UL97 is a viral kinase which is helping ganciclovir to become an active form. But maribavir is inhibiting UL97, that is causing decrease in the viral load, right? So you cannot combine ganciclovir with maribavir because one needs UL97 for the activation. Can someone online? There is some noise. Can you mute yourself? Thank you. Yeah. So all the combinations are possible, especially maribavir and letermovir are very soft drugs. If you keep giving them, there is a high risk of resistance. Even in refractory diseases, maribavir, eventually people have accumulated mutations to maribavir. One interesting thing is there are some mutations in UL97 region which can cause resistance to like ganciclovir, but they can make it hyper susceptible to maribavir. Similarly, what we see in HIV, like M6460V, which is there, probably a good MCQ for quiz. So you are giving ganciclovir and patient develop M64V and patient is resistant to ganciclovir. Now you give maribavir, patient will respond more than better because the virus is hyper susceptible. Okay, so this is one study, solicited study, which we keep quoting about maribavir. In this study, you can see that in patients with refractory CMV disease, compared to whatever other treatment you have in the combination of other antivirals, maribavir has definitely done well. But once you stop maribavir, in next few months, you can see only less than 50% of the patients are CMV viremia negative. They are relapsed again. So it's a very soft drug. So once you, in this study, they have kind of stopped maribavir at 8 weeks without giving any secondary prophylaxis. But if you are treating a refractory and relapsed disease, probably the ideal strategy will be give maribavir, clear the viremia, and put the patient on secondary prophylaxis, probably with letermovir if you have a lot of money, right? So maribavir and letermovir are kind of drugs which are little bit soft drugs. And what about secondary prophylaxis? Do we need to treat all CMV disease or viremia once you have treated, once the blood is negative or patient has improved? Shall we stop the antivirals there? Or shall we continue secondary prophylaxis for some more time? This is not very well answered. Many other times people don't use secondary prophylaxis. I try to give secondary prophylaxis all the time, but the real answer will be if you can measure the immunity, if you think that the patient can take care of whatever CMV reactivation is there, probably that is the time you want to stop secondary prophylaxis. So measuring cell-mediated immunity in deciding secondary prophylaxis can also be helpful. If you look at this study, again, this study, the conclusion is secondary prophylaxis is not helpful to prevent subsequent CMV disease. But if you look at the mortality again, patients prophylaxis had lesser mortality. Again, the CMV viremia comes into play. A CMV viremia is not just CMV viremia, it can affect a lot of things later on, right? So before concluding, we will quiz again. So what is the answer now? So I expected a louder response. What about this is easy. And what about this? Preemptive treatment is associated with high CMV disease. Is it true? No. Preemptive treatment, not in kidney transplant, of course. In liver transplant, at least preemptive treatment is associated with lesser incidence of CMV disease. But obviously, preemptive treatment will have higher CMV viremia. So that is also false. And negative blood and CMV will not rule out a CMV disease. Approximately in 50% of the cases, that's a very big number. So someone is having diarrhea, you have done blood PCR negative, you haven't ruled out CMV, not at all. And now you can answer this question. UL97 mutations are associated with cidofovir resistance, true or false? False. UL97 mutations and UL54 mutations in DNA pyrophosphate region, that is region 5, will cause foscarnet and ganciclovir resistance, but not cidofovir resistance. True. Complicated. There are reason 2 and 4 mutations are associated with resistance to both Cidofovir and ganciclovir, right? And there are no mutations causing cross resistance to maribavir and ganciclovir. This is also wrong. There could be cross resistance to maribavir and Cidofovir. So it is not like patient is maribavir and ganciclovir. It's not like a patient didn't respond to ganciclovir. He will be obviously susceptible to maribavir. Most of the times it will be, but there are some mutations which can cause cross resistance to both also. So to conclude, CME is a transplant role. Even CME viremia has a lot of indirect side effects, which will have implications in overall graft function and overall survival as well. Measuring cell-mediated immunity in CME might help. Probably measuring immunity is the big area. So our genome has approximately 5% of endogenous retroviruses. Tenovirus is one of them. It looks like our all presentations are finally leading to tenovirus. So it is gonna probably, if you see the reactivation of endogenous retrovirus, probably you can measure immunity. Not very clear right now, but we'll see more about it later in the day. Mini dose prophylaxis is not obsolete. So the guidelines which were recently concluded, no statement about mini dose prophylaxis, but it's a very interesting strategy. The problem is the evidence is not very strong enough to make it into guidelines, but there are a lot of literature which is accumulating. And it is really a option to look for LMICs where the cost of antivirals is quite high. Let him move for prophylaxis, not for the treatment, because if in high viral load letermovir, there will be resistance to letermovir, especially with UL56 mutations. And maribavir we can use for refractory diseases. There is a good evidence for this. And there are a lot of unmet research gaps, especially coexisting rejection with CMV reactivation. We really don't know what to do at this point. Thank you.
Thank you, sir, for that highly insightful and clinically relevant presentation. We'll now break for a tea for 10 minutes. I request everyone to return by 3:30 p.m. for the next session.
Any questions online? Yeah, you from yeah. You can like position player on it. Next.
This is not sharing. Sharing.
Listen for. Let it be off. Somebody comes in. Your Saturday is your eating. Your third Saturday. Yeah. Those are the Saturday. Principal. You know, you're coming back this year. December. And something by December. People have late last country, not talking. Kidney suppression, hormone suppression. When are you planning to do? Yeah. Seriously, can't be 4 hours. Mechanism. Some 5-6 cases in computer. Yeah. Next. August. Yeah, please, 3 holidays. Yeah.
ಇಲ್ಲ ಮೂರು
So now how are you going to
ಇಲ್ಲ
Yeah, what is see, I have that within matches. Because somebody has come, I cannot take her. But outside the so with wheelchair I have to be posted only completely.
How did it happen actually?
No, not in experience. Coming back to my experience for the like when I spoke to them, I mean, you reach my car. This one was that. It was posted. I have 3 options there. Manual, one. Screws, 1K, and
not even daily. I'm scared of dog bites and snake bites. But you need to care, right? You take care of it. Really? All right. Let's get on. Yeah, around. After going for college now, the dog and snake will be there. I'm scared of that. Very easy. Monday college will be. In the college, going. How do you say based on the costing zone? Also, develop right. Today is the holiday. Attendance rate will have that.
ಕಾನ್ಫರೆನ್ಸ್ ಇದೆ ಕಾನ್ಫರೆನ್ಸ್ ನಡೀತೈತೆ
Lights are like. Lights on. Moving to winter this start. Supposed to know. Treatment is different. Example of virus is not when it comes up never came 900 gold.
You understand that. One patient. By the time the report of the patient is already looking there, so when you're suspecting the incidence, this thing is a big chance already. Wait for the report. Will not even not there. It is a possible
Welcome back, everyone. We will continue with the sessions now. Our next speaker is Dr. Nitin Gupta, Associate Professor, Infectious Disease Department, KMC Manipal. He'll be presenting insights from systematic review on adenoviral nephritis. With pleasure, I now invite Dr. Nitin Gupta to his talk.
We're going to talk about a systematic review that we did, adenoviral nephritis in adult kidney allograft recipients. Just a disclaimer, I was neither the first or the corresponding author in this. So any criticisms that you have should be directed to Swati Kiran, who's the first author, and Praveen, who's the corresponding author. The second disclaimer is I usually work with tropical infections. So transplant is not my area of interest or forte. So again, if there are any questions, directed towards Praveen. So why this topic? First is that Praveen comes with some 8 different ideas every day. So this is one of that idea. And my job is he's like the Abhimanyu who goes into several different chakra views. So I just choose one of the chakra view that, of which we can come out together. So this is one of that topic that of the 8 of that day, this was one of the topics. So, and frankly, I had never thought about adenoviral nephritis before this. Hemorrhagic cystitis because of adenovirus is a known entity, but adenoviral nephritis, not that common, would not be something that you would think about all the time when patients come with nephritis in a renal transplant patient. So a little bit about adenovirus. It's a DNA virus, naked virus. It's important to know whether a virus is naked or not because naked viruses can cause GI issues, and naked viruses are very difficult to control in terms of infection control. So not easily cleared with the routine alcohol-based, antiseptics or disinfectants that you use. In general, adenoviruses are very common in pediatric patients. They're associated with some febrile illnesses, upper respiratory tract infections. Two common syndromes that you would have heard would have been pharyngoconjunctival fever or epidemic keratoconjunctivitis, basically mostly related to some URTI and then some conjunctivitis related with some preauricular lymph nodes. Other than that, in immunosuppressed patients, you can have also adenoviral pneumonia. It can be sometimes deadly. There are several serotypes of adenovirus, and they are combined into serogroups, none of which is really important right now. But what we are talking about is that in kidney transplant patients, adenovirus can cause nephritis. And what are the peculiarities? More than that, because my primary role here was also to guide the methodological part of the systematic review. So I'm going to discuss a little bit of how we went about doing the systematic review, and then our findings in terms of adenoviral nephritis in allograft recipients. So the point is that, we have discussed both the previous talks were related to nephritis post kidney transplant, and how it is very difficult to distinguish infections versus rejection. And within that infection, there are multiple causes, and adenovirus is one of this rare cause. Because it is rare, you will not find a lot of data on it. It is usually isolated case reports related to this. So what we wanted to actually know was that what is the clinical profile of adenoviral nephritis? It is different. Is it different from others? Pathologically, is it different from other infections or rejection? Is there a difference? What is the time period when this adenoviral nephritis will present post-transplant? And whether there is any difference in terms of clinical features and outcome between early and late adenoviral nephritis. And in general, is the outcome relatively good? Does it lead to a lot of graft loss or not? Are there any treatments related to it? Whether treatments work or not? And then basically predictors of people who have irreversible graft dysfunction due to adenoviral nephritis. So, like everybody should know who do systematic review, that there is some checklist, Prisma checklist for systematic review, and you should know what all these points are. So this was a systematic review that we did in compliance to Prisma guidelines. We registered it to Prospero. So now, in general, when you're doing a systematic review, ideally you should register it to a agency like Prospero. Prospero is the most commonly recognized one. And what is recommended that when you are searching for the articles, you should at least have 3 databases. So we chose PubMed, Embase, and Web of Science, which is the most common ones. Cochrane recommends Cochrane's database to be included, but since we were not anticipating randomized controlled trials in such a rare topic, so Cochrane was not something that we were interested in. So PubMed, Embase, and Web of Science is commonly what we select for medical systematic reviews. Here, the PICO format does not usually work because this is a kind of a descriptive thing where you are interested in understanding the clinical profile and outcome. So the population is the one that is more important, which is the adult renal transplant recipients, and outcomes here are multiple that we have discussed before. So again, we defined confirmed adenoviral nephritis. It's important to know what is confirmed adenoviral nephritis is that if there was a biopsy done and PCR was positive or IHC for adenoviral antigens were positive, and presumptive was that there were clinical symptoms, but along with that, there was viruria, that is adenovirus in urine, or viremia or DNAmia adenovirus in blood. And we defined early versus late as less than 90 days and more than 90 days, just to see whether when does adenoviral nephritis present and are there any difference between clinical profile and outcome. So when you create a search string when you're doing a systematic review, ideally the search string should have at least your population and intervention control whenever it is there. Outcomes are usually not kept in your search string, and you use certain Boolean operators to combine it. So we use something like adenovirus or adenoviral plus kidney and several different names for kidney, so renal and transplant. So these three search terms we combined, and this gave us in different databases some 1842 records. The next step that you do is you do a deduplication because you're using three different databases. There will be a lot of duplicates. So you remove these duplicates and then you do a title abstract screening. So title abstract screening is again done by two people independently. And you just see the title and abstracts and you decide whether you want to include or you don't want to include. And this is whenever you have doubt, you include in title abstract screening stage. Then the third reviewer will just, if there is any discrepancy between the first two reviewers, then the third reviewer will decide whether it should go for the next stage or not. Next stage is the full text screening. So you download all the full text, you contact the authors, do whatever you can to acquire the full text, and then you go through the full text to see whether this meets your eligibility criteria or not. So eventually we landed up with both these phases of screening. We landed up with 39 studies and a total of 57 patients. So our intention was, because this is a rarer entity, we wanted to take the individual data of the patient to have any meaningful analysis. So it is a sort of an individual patient meta-analysis, not exactly individual patient meta-analysis, but this is entities if you want to understand them properly, because very unlikely that any one single center is going to give you 50 patients for a rare entity. So this is something that might be helpful. So then there is a step of critical appraisal. So JBI has some checklists for case reports that we use for just seeing whether they meet your basic standards for inclusion. So sometimes case reports are focused only on the radiology or the histopathology, and they don't talk about clinical profile and outcome, which is something we. And so if they do not have these details, then usually they are not included. So anyway, so these 57 patients, individual data were collected and then they were analyzed. So mean age was 45.7 years, 74% per male. Median time to infection is 168 days. So it is usually happening late in the course of post-transplant. And most of these patients were cadaveric donors, likely because cadaveric donors may be more immunosuppression, so more chance of an infection occurring. Clinical features, fever was there in 68% of the patients. The important part is that adenoviral nephritis can present without fever. So, usually when you think of infection, you associate it with fever. But again, in post-transplant period, patients who are on immunosuppression, fever can often be masked. So, dysuria was present in 49% of the patients. So, like I said, in before adenovirus, one important manifestation of adenovirus, which is better recognized as adenoviral hemorrhagic cystitis. So, concurrent cystitis was present in half of the patients. You can also see that gross hematuria was there in 51% of the patients, but microscopic hematuria actually was more common. And because we are talking about nephritis, so graft dysfunction was there in almost all of the patients. Radiologically, findings were often non-specific. Hydronephrosis, because again, like I said, again, you can associate it with hemorrhagic cystitis, is that some blood clots can be there, which will lead to some hydronephrosis, and hypodense lesions in CT were described in some. And there were some mass-like lesions in some of the patients that were described, but there were very few reports that actually gave radiological findings. So, but important thing is that radiology can be normal. This is the interesting part, and this is where probably the question started, was histopathologically. You will see that a lot of these patients have granulomas and necrosis. And when you think of granulomas and necrosis, you think of TB. And often, because it is very difficult to establish TB in such patients, these patients will inevitably be started on ATT. And that was the important point. Probably the highlight point of our systematic review is that necrosis and granulomas are very, very common in adenoviral nephritis. So the other thing was that a lot of these patients had neutrophilic infiltrates, which again you will associate more with a bacterial infection and not with a viral infection. So this is something that will tell you that probably this is, you know, something different is happening at least. The other thing was that vascular involvement, except for one patient, nobody had vascular involvement on biopsy, which is something that you can see in CMV. So that is something also that was unique. Now, again, very little is known about treatment for adenovirus. In vitro, what we know is that cidofovir works in vitro well for adenovirus, more than, let's say, ganciclovir. But like previously, it has been discussed that cidofovir is associated with a lot of nephrotoxicity. So usually when you give cidofovir, you give like a 5 mg per kg weekly dose of cidofovir. So for these patients who already have graft dysfunction, what you can do is, what has been suggested again is that you can give a lower dose on alternate days, or daily dose of cidofovir can be tried, and there is some recommendation that you can skip the probenecid dose that is usually given with cidofovir. So some cidofovir was tried in 28% of the patients only, but again, low number of patients, not much can be concluded based on that. But most of the patients, like for any infection, immunosuppression was reduced, and you start with stopping MMF in most patients. And IVIG was tried in 54% of the patients. The outcomes were usually good. 75% of the patients had reversible dysfunction. So once you decrease the immunosuppression with or without antivirals, most patients had reversible dysfunction, but 14% there was graft loss. And in 5% of the patients, it led to death as well. So we, based on whether they had the graft function reversed or not, we compared the two arms, and we saw that that graft dysfunction was more commonly, irreversible graft function was more commonly seen with deceased donors, possibly because maybe more immunosuppression. And dysuria was more common with reversible graft dysfunction. Again, it's difficult to say, but what we thought was that dysuria or macroscopic hematuria will alert the physician early towards the possibility of, adenoviral nephritis, detect early and reduce the immunosuppression. That could be a reason why macroscopic hematuria or dysuria was related with reversible graft dysfunction. So wanted to see that whether there was any difference between early versus late. Like I said before, most of the patients, the median time was around 160 days. So most of the patients presented late. But when you compare early versus late, what you find was that fever was more common in late adenoviral nephritis. Again, our assumption was that because in the early period, patient had received induction therapy, more immunosuppression at that point of time. So maybe fever would have been masked at that point of time, but nothing significant came out between early and late. So the idea is that adenoviral nephritis is difficult to differentiate from CMV or BK. Clinically, dysuria may be present and macroscopic hematuria may be present in 50% of the patients. That might give you some pointers. Biopsy actually will help. So if you see, think of, there is nephritis, and if you see necrosis and granulomas, you can probably think of adenovirus. And, urine PCR or blood PCR can actually help you in these cases. Again, systematically, large-scale prospective studies have not been done to see what is the incidence of adenoviral nephritis. This is something that is an area of interest for us. As at present, of data on antivirus, like I said, and the problem is that cidofovir is nephrotoxic. So you need to, in terms of immunosuppression, is the only thing that you can do. But like I said, rejection is one of your differentials in such cases. So you have to balance the risk of rejection versus the risk of complications due to the infection. This is just a small systematic review based on an idea that we had. This has a lot of limitations. So all of these were case reports or case series, and you cannot conclude a lot based on that, but at least you can find a pattern. So the idea is, the conclusion is that you can think of adenoviral nephritis in some of the patients if they fit the pattern that we have discussed. And we could not do regression analysis because the number of outcome events were not huge. Anyway, so the summary is that adenoviral nephritis is uncommon, but very likely underdiagnosed. It has diverse presentations in terms of clinical presentation and radiological findings. Histopathology is probably the key to diagnosis. And at least as of now, what we understand is that prompt reduction in immunosuppression is something that might be helpful in adenoviral nephritis. Thank you so much.
Thank you, sir, for that engaging and informative session. As we move into our final scientific session, it's my pleasure to introduce Dr. Aravind Ramanathan. Dr. Ramanathan brings over 2 decades of expertise in molecular oncology, immunology, and translational research. He is the founder director of Enable Biolabs India and holds a PhD in molecular oncology from the Tokyo Medical and Dental University, Japan. Today, he will address the topic, assessing the net state of immunosuppression. Are we there yet? It is my pleasure to invite Dr. to deliver his talk.
Inviting me, and fantastic, excellent post here. Okay, so a quick introduction of myself. So I graduated with a BDS in 1993, and then I switched to genetics, and then eventually a PhD from Japan. And until 2010, I worked at Riken Brain Science Institute and Duke NUS Singapore. So Riken Brain Science Institute is the one place where you do anything and everything about neuroscience. And I was working on the Drosophila, the fly larval peripheral nervous system. So I used to purify just 10 neurons from the larval system. And I have good publications in neuron and other high impact factors journals. So in 2010, all right. So while working at Riken Brain Science Institute, so the director happened to be a Nobel laureate, and he liked, for some reason, the Indians very much. So we always had the privilege of talking to him, and he motivated that I should go back to my country and then contribute whatever I have learned from there. So eventually, in 2010, I returned back to India to set up a lab in Chennai. Although I had offers from IIT, Kanpur, Guwahati, and other good institutes, I decided to set up a lab to focus and do just what I wanted to. So I specialize in developing genetic technologies for personalized medicine. Like, so for example, there are a few people with the same diagnosis, same prescription. The medication may work in some and it may not work in others. For example, a very simple example is the clopidogrel, the clopilate, the antiplatelet medication. So it is actually sensitive in only 33% of the population. But rest of them, they're pretty resistant. So you can do a genetic test and tell which patient would be actually sensitive to clopidogrel. Okay, so these kind of tests, like or were quite rare when I came back to India, so I started offering them, and there are many other such tests that I have developed. So today I will focus on the transplant-related segment. You can see, the post-transplant, during the post-transplant period, achieving optimal immunosuppression is a big challenge. So either high immunosuppression can lead to infections, under-suppression can lead to rejections. So most of the transplant physicians, they use the plasma tacrolimus level as an indicator for optimal suppression. The plasma tacrolimus level is not a direct indicator for the optimal suppression, right? So to address this, I started doing this virus assay. It is something not that I started doing it. They were already doing it, around the world. But in India, I started doing it for the first time. So I developed a very highly sensitive kit that is able to detect the virus with high degree of sensitivity and specificity. So a little bit about the virus. It is basically a small DNA virus. There are 40 genotypes of this virus, and they are non-pathogenic, and it's present in about 90% of our population, and it causes low level of viremia in most of us. But the titer of this virus need not be the same in every one of us. So it can be 10 times 5 in one, maybe 10 power 6, or maybe 10 power 10 in some. So, or in some, it may not be there at all. So the titer is not uniform. And it proliferates in just not in the T cells, but it also proliferates in many other PBMCs, and then hematopoietic stem cells and liver also. How do we use this to gauge the immunosuppression? The immunosuppression and the virus titer, if the immunosuppression is high, the viral load also will be higher. If it is immunosuppression is low, the viral load is also low. Why? Because if there is a higher immunosuppression, the T cell count will be lower, right? So higher antiviral capacity. So lower antiviral capacity. So you'll have a higher TTV load. If the immunosuppression is lower, the T cell count will be higher, and the TTV titer will be lower. Okay, so achieving the optimum. So in case of if the T cells are too low, below a particular threshold, it exposes the patients towards developing it. But if the T cell count is higher, then patients become susceptible to develop rejections. So achieving the optimal immunosuppression in between is the key to for a successful transplant. So how do we interpret this TTV titer? So every one of us, we have a particular level as a stable TTV titer. Anything above that can lead to infection, can indicate infection, or anything less than that can indicate a rejection. So if the immunosuppression is higher, the TTV cells are lower antiviral defense, so you will get a TTV titer is higher, so it indicates infection. The vice versa is for the rejection. So this is an example from a kidney transplant recipient. So we started doing this recently, starting from day 0. It's a pre-TX, right? And then day 7, day 15, and then day 30. So you can see that during day 0, the level is like 2.6 10 power 5. It's like close to 2.6 lakhs. And then it increases day 7, day 15, and then by day 30, it has reached close to the pre-transplant levels. But what you have to focus here is that the whole difference is not much higher. And the creatinine level also was maintained stably here. This is from a lung transplant recipient. So immediately after the transplant in 2023, the viral load was higher, and then slowly it came down, it stabilized along with the graft function, it was very stable. But after November 23, we lost the patient for follow-up, and eventually he returned back in April this year with graft dysfunction, and we found that the TTV titer had fallen down drastically. So when we did the liquid biopsy, the cell-free DNA, the cell-free DNA level also was very higher, and the biopsy confirmed acute cellular rejection. So what you can really understand from here is that if the TTV titer falls below a particular threshold, it can lead to rejections. And this is a very strong correlation because we also have an elevated cell-free DNA. This is from a heart transplant recipient. So for some reason or other, this patient is quite affordable one, and so we did that assay almost every month. Right from the beginning, it appeared that he was undersuppressed. During the 5th test, right, the biopsy showed acute cellular rejection. And then the immunosuppression was raised, and eventually the viral level stabilized. So when do we do this test, or for whom should we do this test? Right? Either we can do it for all, right from the pre-transplant, or whenever you suspect there's an episode of infection or rejection or any other, some other pathologies. Especially when you are going to switch the drugs, or when you want to increase or decrease the immunosuppression, or when you have patients who are at the high risk of developing infections. So I'll address the first three. Okay. So for new transplant recipients, you can start the test from day 0, 7, 15, and first month and second month maximum. If you do this first 5 times, we will be almost able to understand the success of the graft within this first 5 tests. If there is the fluctuation not going to be too high, then we will know that the graft will be successful. Or for those who have already received that allograft, how do we deal with them? So the first sample should be collected when the creatinine is stable. Because these tests, it doesn't work like a CME or BKV or other test. This is a non-pathogen, so we always need a first sample that will be used as a reference for all the subsequent tests. So the first sample we take when creatinine is stable. And then the second sample can be at the time of suspected pathology. But in an ideal world, right, so when the creatinine is normal, we can never convince a patient to do a test. That's the ground reality. And we also won't feel like asking the patient to do a test if everything is normal, right? So what we can do is, in those patients, you collect the sample at the time of suspected pathology. If you decide to increase or decrease immunosuppression or change the drug, you can go ahead and do it. And then we can repeat the test maybe after 3 weeks or 4 weeks, or maybe after a couple of months. That way, we will have compared to a reference, we will know based on the TTV titer whether the intervention worked or not. The other way to do is you do a TAC metabolizer test, and we usually store the sample. And when you suspect a pathology, then we can repeat the test. So the sample from the TAC metabolizer test can serve as a reference. Right? So I will show an example for the third. So this patient, the transplant happened sometime in January. We did a TAC metabolizer test. And then recently, the patient started developing viral warts and the creatinine started increasing. Okay. So this test I completed yesterday. So the first time before the transplant, the TTV level was undetected. But yesterday, when we checked it, the titer had raised enormously. So this indicated oversuppression. So oversuppression, so probably has developed viral wart. Interestingly, for this particular patient, I predicted that the risk of infection is very high. Okay. So what is this about? So when do we do this assay? So first three I addressed. This particular, the fourth point, the patients who have the high risk of developing infections. So this is a predictive test. So it can identify patients who have a high risk of developing sepsis leading to mortality. So if you see in this particular group of patients, those with high risk genotype, the mortality was close to 23%. And those with moderate and low risk, there was no mortality. And if you also see in the low risk group, the graft stability was also very, very high. So this test is based on an genetic assay. So we screen a lot of single nucleotide polymorphisms, and then based on an algorithm, we categorize them as high, moderate, or low risk patients. So by doing this test, I have been able to predict now, this is around 89 samples. Now we have reached close to 120, 130 samples so far. And every time the data correlates very well. So we call this test as infection risk genotype assay. So from this, it's very clear that optimal immunosuppression is very, very important, right? So for us to achieve an optimal immunosuppression, we have to, most of us probably rely heavily on the tacrolimus. And the metabolism of tacrolimus depends on CYP3A5 group of enzyme. And based on the polymorphism, they're categorized as extensive, intermediate, or poor metabolizers. Extensive metabolizers require a very high dosage, poor metabolizers require a very low dosage of TAC. For most patients, so for most of the patients, this test is not required. For most of the patient, it's not required. So you give a TAC and then do a plasma TAC level, you will know, right? So based on that, you are going to adjust the dosage. But this test acts, it is something like your seatbelt and airbags. At the time of crisis, you won't know whether the patient requires low dosage or high dosage of TAC. So but if you do this test, if you have this data, if the patient carries a poor metabolizer genotype, you can be certain that this patient will require only low dosage of TAC. So you can adjust the other immunosuppressors. There are many other advantages for doing this test also. If the test is not done, then you will have to do more number of plasma TAC assays to achieve target tacrolimus level. But if you know the genotype of this particular patient, say for example, if you know that a particular patient carries a poor metabolizer genotype, then you can start with a lower starting dosage. So you will have to do a less number of plasma TAC tests to achieve target tacrolimus level. So this data has been published already by Dr. Edwin's group from Stanley. So you can see that a day 4 C0 has been, target tacrolimus level was achieved in 53.6% of these patients. Day 10, 47.5% of the patients. And number of times that were required to achieve this target tacrolimus level, only 47 times. And the subtherapeutic dosage was much lesser compared to the control group. So this test actually helps to achieve the target tacrolimus level much easier. So now I spoke about these three metabolizers, no? Extensive, intermediate, and poor. So in most of the extensive group and poor metabolizer group, the dosage requirement is very clear. But in the intermediate group, the dosage requirement is varies. Some patients would require very low dosage, some patients will require very high dosage. So now I have developed one more test that can tell us the exact dosage for these poor metabolizers also. So is this actually overdose for you? Like, can I stop here or can there's one more test? This is called a liquid biopsy. You probably have heard about this liquid biopsy, right? So there are some drawbacks for this surgical biopsy. Patient has to come and then you have to do, take the tissue. There's scarring issues and all those things. So to overcome these issues, we have developed this thing called as liquid biopsy. So the liquid biopsy that is currently available is based on the DNA. It's called donor-derived cell-free DNA. So what I have developed is called as donor-derived cell-free RNA technology. So because each of the organ it has its own RNA. It is not the RNA that is expressed in heart, lung, or not expressed in kidneys. So RNA expression. So I take those as markers, then I do the assay. So if you see, this is from a heart allograft recipient. On day 40, the DNA, cell-free DNA was higher, but RNA was not high. So biopsy was normal. And day 90, the DNA level also increased, RNA level increased, and biopsy showed antibody-mediated rejection. So in case of DNA, whenever there is an infection, DNA level also goes up. The cell-free DNA level also goes up. But RNA level goes up only if there is an infection. So we have confirmed that the positive prediction value to be 68% and negative prediction value is 93.5%. This, when we compare with the US technology, the positive prediction values are around 9% and negative prediction is 97%. So this data is based only on the heart transplant recipients. So we are yet to do this on the kidney transplant recipients. Okay. Besides that, I have several other research in pipeline, and this I showed the initial data, the risk of infection prediction assay. The next thing that I'm going to do is detection of infection on the bedside. So all you have to do is take a drop of blood and then put it in a device, and you will be able to predict the infection in less than 2 to 3 minutes. So I have succeeded in the pilot scale study. So now we have to go for the clinical validation. So now overall, like for the Toctinovirus assay that I was talking, it's not a test for one particular drug. It is just not for the tacrolimus. It is for all the immunosuppressors overall, right? It gives, if you observe a variation between the first baseline value, then if you know the CYP3A5 genotype, then you don't have to adjust the tacrolimus directly. You can play around with the mycophenolate or the steroids. So this will help you to understand the overall immunosuppression and then decide which drug should be adjusted. Okay, so with this, I'll conclude the talk. And if you have any questions, you can ask. And importantly, my expertise is not, as you have understood probably by now, I'm not a clinical expertise, but if you have any new ideas or issues, I can convert it into a technology that can be marketed. And so that eventually, the patients will benefit. So my thing is now probably next 2 years, I will leave the diagnostic segment. Then I'm moving into the therapeutic segment. So the therapeutic segment will address patients with sepsis first. So we are developing a kind of a device to reduce the population of microbes, something like that. So all the pilot scale, everything works, but eventually we'll have to do it at a larger scale. So if you have any ideas, you can always discuss with me and we can collaborate. I can develop it and commercialize that. Yeah. Thank you.
Thank you, sir, for the thought-provoking presentation. We would now like to present a token of gratitude to Dr. Aravind Ramanathan. I cordially invite Dr. Muralidhar Verma, Professor and HOD, Department of Infectious Diseases, KMC Manipal, to present a memento to Dr. Ram. Thank you, Dr. Muralidhar Verma and Dr. Aravind Ramanathan. The floor is now open for a 15-minute question-answer session. Participants to unmute and clarify your doubts.
There's some existing questions in chat. Questions are the same. Okay, fine. So one question that was relevant is, do you ever came across ganciclovir resistance in clinical practice? And in such cases, what is your management approach? This is very interesting when you discuss with a lot of colleagues from other centers. Most of them will come up with an answer of like, we never have seen a ganciclovir resistance. But again, we have to keep this in mind that we really don't send for resistance genotyping most commonly. Like per year in every center, 1-2 patients you'll be sending. So the risk of treatment failure in CMV is not just related to resistance, definitely. Most of the patients, you have to adjust the immunosuppression. And the resistance you will actually find very rarely. So we have sent for few patients. In our clinical practice also, we never found a resistant mutation till now. But I would say that our clinical practice is very limited right now to the ganciclovir resistance. The another question is, at SGPGA Lucknow, we test CMB biopsy by RT-PCR and give report in number of copies per milligram of tissue. A load more than 250 copies per milligram of tissue is suggestive of CMV colitis. I completely agree with it. If you give me this report, I'll be tempted to treat CMV, but I'm very sure this data is from inflammatory bowel diseases, which we cannot kind of extrapolate it to transplant recipients. And at the same time, when you have a CMV viremia active, if you are running a PCR in tissue, there is a criticism that you might pick up that CMV PCR from the blood in the biopsy tissue, which will be very difficult to interpret. However, there are actually new strategies in IBD setting. We are looking in gram tissue, and there are many studies. Some are positive, some are negative, with different thresholds to treat it as CMV colitis. Even in CMV pneumonitis, people are adjusting the ball fluid for the number of cells. So if you do a ball and you count the CMV viral load for 10 power 6 cells in the ball, inflammatory cells, then you will get one threshold. And most of the times that is around 10,000. Based on that, you can take a call whether to treat the patient or not. But these thresholds are different in different studies. But I do agree there is some literature, especially in the inflammatory bowel disease setting. Only 2 questions, sir. Yeah. Thank you. How many adenovirus, sir? Sorry.
How many of them were in
So adenoviral nephritis can be isolated, sir, especially early adenoviral nephritis. So if you divide it into less than 90 and more than 90 days, so those are the patients in late adenovirus, more than 90 days. Most of the times they can have a systemic infection that will land up in kidney. Like for example, someone developed adenoviral pneumonia that eventually became adenoviral nephritis. So as a part of disseminated infection, in early adenoviral nephritis, less than 90 days, it's very common to have isolated adenoviral nephritis. So patient will have only kidney involvement without other system involvement, which will make it very difficult. Total number of cases are 56, sir. Extrarenal manifestations were less than 15 patients. So that's what I'm saying, sir. In first 3 months, very
Number
small,
is very small.
and patient can actually come with a isolated involvement of kidney.
If the adenovirus is there in the kidney,
Yes, sir.
it's not like
It's not like patient had adenoviral pneumonia dissemination and then had a adenoviral nephritis. It is like isolated nephritis. So patient will come with a graft dysfunction. Some of them may or may not have hematuria, and early adenovirus they might not have fever also, which is an important symptom where we'll think about a possible infective etiology. So it is possible that the patient came to you with a progressive renal dysfunction, and we have done a biopsy that is showing extensive tubulocentric inflammation, which we'll think as a cellular rejection. If we are not running an IHC in that sample, we are likely to miss a possible adenoviral nephritis, where the treatment is completely different from rejection.
and mechanism, granuloma.
So adenovirus is one virus. Again, it is associated with very extensive inflammation and necrosis. That is the reason why some of these transplant patients actually have some mass-like lesions or space occupying lesions. So you will think that it is probably PTLD or something. So adenovirus is the one virus. So there are three different viruses which we have discussed today: adeno, BK, and CMV. And if you look at the histopathological features of all these three, immunologically they are quite different. So by the time you have some asymptomatic renal dysfunction and you do biopsy, if you see a BKV nephropathy, there will be extensive fibrosis disproportionate to whatever the clinical course you have seen. Whereas in adenoviral nephritis, you'll have an extensive tubulocentric inflammation, necrosis, and because of the high TH1 response, there could be formation of granulomas as well. Whereas in CMV, you see vascular involvement. CMV nephritis alone is little uncommon, but if you see that, you will see some vascular involvement. So if you're seeing vascular involvement and thinking about infection, it is CMV, extensive fibrosis. In fact, in BKV, the tissue biopsy sensitivity is very poor, because most of the times you do a biopsy, you'll see fibrosis, but the IHC for BKV negative. So if you're seeing a lot of fibrosis disproportionate to what you're expecting, think about BKV. And adenoviral nephritis, the granulomas and extensive tubulocentric inflammation. If you if you decrease the immunosuppression in adenovirus, the prognosis is very good. Usually the kidney recovers completely, which is not the case with BKV. You'll have some fibrosis already existing in the kidney.
Which other virus is called granuloma?
This is a very interesting question, how to think about it. So granulomas are very non-specific. It's a post-inflammatory response. So we see EBV granulomas, we see CMV granulomas. Herpes we didn't see. I am sure there are other viruses. In EBV also it's very common. So there are many patients who present with hepatitis and you do a bone marrow, there will be bone marrow granuloma. It is easy to confuse as a tuberculosis, but it could be a CMV hepatitis with granuloma and EBV granulomatous disease also. Sir, even in among the, yes. Yeah.
What about non-renal transplant immunosuppression like bone marrow? They have this.
So adenoviral, so a solid organ transplant, the important thing is the graft itself is more immunosuppressed than whole host. So in solid organ transplant, many of the times, even for example, you have a donor from a TB patient who is missed in the screening. So active TB has donated a kidney to a recipient. It is likely that the recipient will have tuberculosis in the kidney. So the graft is more immunosuppressed. So most of the reactivations can happen in the graft in solid organ transplant. Where in HSCT, we usually see a systemic infection. So in HSCT setting, adenovirus pneumonitis is a problem. Rarely hemorrhagic cystitis. Yeah.
Is it possible to clinically differentiate adeno or BK virus?
That is what we are discussing actually. So when you are looking at a patient who came with a, let us assume, asymptomatic progressive renal dysfunction, where you are thinking about a lot of other possibilities along with adeno and BK, Adenovirus, people can have fever up to 50%. And if there is some hematuria, microscopic or macroscopic, that might favor adenovirus. And if you are looking at a radiology which is showing mask-like lesions, besides other differentials, you also have to think about adenovirus. But once you do biopsy, the biopsy picture of BKV and adenovirus is quite different.
Either BKV is relevant to other transplant, except
virus relevant to other transplant except renal.
No. It's very, very rare to have a BK viral nephropathy in non-kidney transplant. That's what we are discussing about. The graft immunosuppression is more, and many of these viral infections or other infections tend to relapse in the graft. There is one more comment that there is a center which is doing acyclovir resistance, and in solid organ transplant there is a 3% in SOT and 10% in HSL. That's interesting data to have. It is rare to have a acyclovir resistance, but again that is a problem. Yeah.
one correct.
So, I think around 2005.
Probably no. Like we can send samples.
Yeah. But if you're going to do it as a study, then
And the other thing I want to know is that virus is for T cells, right? Basically, it will tell, or you can say overall it is
overall it not
T cells. Helpful for overall. So can we do it for irrespective of the what you can say the transplant date? Like I'm not telling for only renal transplant. Now it is coming across renal transplant. I want to know for anybody before I start an immunosuppression.
Most of the data I think it's come from the lung transplants. So I have done. So I have done extensive of lung transplant.
So that I agree. Like in the transplants, it is using people immunosuppression, want to overdose, all those things. I want to say like in a glucose patient, I've given some drugs, not responding, want to add a couple of drugs, but so in that patients also can this virus can do something.
Yeah, as long as it is immunosuppressor, definitely it's
You can just, but you think the levels are individualized or what?
Definitely. Definitely.
So always having a baseline before immunosuppression is
It's a clear piece. So the last case that I showed, so pre-transplant the patient didn't have. So it is not unusual to know. So several people have reported, but after the transplant, 2 to 3 months later, they'll start again. They may, some patients may develop it. So there's one lung transplant recipient. It's more than 3-4 years, but that is clear. So there's no virus in that. So which means that we cannot use this as a test for all the patients. Probably 90% of the patients we can use. For those patients who don't have this virus, we can't.
But the cutoff levels.
Cutoff levels always
universal for all or no? It cannot be individual. It has to be individual.
Say, for example, we may have this one line. I may have 10 lines. 20, 50, 60, maybe 1 4. We change it.
How much it comes down, based on that, you will decide.
Based on the first baseline next, we can use.
Self-free or like only for heart transplant?
No, we did a clinical trial with lives only. But then I lost my interest. There was only other tests that had to be developed. So I was planning for the trial for the kidney transplant. Heart transplant and lung transplant is sequence of which, right? So most of the kidney transplant patients come from average time. So the test that I developed, the average people should be able to do it. But the survey RNA is expensive. It costs around 9,000, 10,000. So 9,000, 10,000 is easy for us, but for transplant patients, it is not an easy matter. So, but the coronavirus test is equally good to the self-care. So we can actually predict, say, if there is going to be a change in the immunosuppression, if there is going to be a change, it will reflect on the type. So you can expect a rejection or an infection. If you're very certain that the person is going to have rejection or is likely to have it, but if you're in a situation where you cannot do a biopsy, then you go to sleep self-ART. If you do the self-ART and if you see this marker, invariably, almost 95% of the time it is rejection. And most of the time, detect self-ART is AMR.
They're using Chennai people are using.
I don't commercialize as to, I don't tell about this.
Basically, it comes to us in a scenario where we have antiplatelets. Even they are on, like on age, they are on life. When we're in dilemma, can we
Of course, you can. So these tests, eventually, in the US and European markets, right, these tests are covered in the insurance. So they do it. But here, so I do this test only upon request from some specific doctor. If the patients can afford, yes, because this test is the sample has to be collected in a specific tube. I need 9 to 10 ml of blood in a particular tube. So the tube has to be imported from Germany. So there's a term price for that. So there's a big process for it.
The genetic assay report
Yes.
for the
This no, this is prediction.
risk prediction.
Yes.
That's how.
No, I'm not charging for that test now, as of now. So I'm just doing it as part of other, whenever I get the tax metabolizer test. And especially I'm doing it for the teams which are giving me the clinical data. Right? So whenever the patients have a high risk genotype, they become a group. They develop infection even if the immunosuppression is a little bit high. Invariably they develop. And if they are, approach very aggressively, then eventually they will reach sepsis and mortality. So now I have checked only in the transplant. Patient live in ICU, so that is, so you can suggest me n number of other high risk group patients also. So we can do that as it also. I'm open to collaborations also, academic, commercial. So things that all this technology should reach.
Any more questions? Thank you, everyone. To bring today's engaging symposium to a close, I now invite Dr. Indu Ramchandra Rao, Additional Professor, Department of Nephrology, to give the valedictory address. Good evening, everybody. So this has been a truly enlightening and thought-provoking session. I think we are now leaving with an understanding of how complex the management of transplant recipients truly is, and the complex interplay between viral infections and transplant. So we started off with Dr. Ravindra Prabhu sir's session on the management of BK virus nephropathy in transplant, and he has highlighted the importance of how early detection and balancing of immunosuppression is important to preserve graft function in these patients.
We then had a very comprehensive overview of the management of CMV in transplant patients by Dr. Praveen, where he has highlighted the evidence gaps in management and how exactly we can navigate these challenges. We then had another very interesting talk by Dr. Nitin Gupta, where he spoke about an entity which is not really well known, adenovirus nephritis. I think it's something which we don't commonly encounter, and we certainly don't read about much in our textbooks. But as he's highlighted, it's very likely that it's quite an underdiagnosed entity. So this is again something which is very interesting. And finally, we had a talk by Dr. Arvind sir, where he spoke about some really exciting new developments which are happening, which may now help us to assess the net state of immunosuppression in transplant patients. I think it's a very interesting area of research, and we now await to see what where this area now goes. So I wish to thank the organizers. It's been a very enriching session, and I think it's helped us all understand the importance of collaborative research, and how important it is that infectious diseases, nephrology, and virology works together to manage our transplant recipients. Thank you very much.
Thank you, ma'am. That brings us to the end of today's program. Our sincere thanks to all the speakers, organizers, and participants for your active engagement in making the CME a success. We hope today's session spark further research and collaboration in the fields of transplantation and infectious diseases. Thank you once again and have a pleasant weekend.